Hello, I'm Ingrid Waldron, President of NAMI PA Main Line, an affiliate of the National Alliance on Mental Illness. Our topic today will be mental illness and violence. I think now you can see the slides, and as the slide shows, we're going to be focused on evidence, research evidence that helps us understand the relationships between mental illness and violence. In specific, we're going to review the best evidence concerning relationships between mental illness and physical violence in the U.S. and other Western countries in recent decades. There will be 3 sections of this webinar. The first will be violence against others by people with mental illness. The second will be violence against people with mental illness, including both violence by others and suicide, self-harm. And the third and final section will be evidence-based approaches to reducing the problems of mental illness and violence. After each of these sections, we'll have a question and discussion period. You can type your questions in, and then at the discussion time, our moderator, Craig DeLarge, will read the questions and comments, and we will discuss them. For this presentation, I'm going to include in major mental illness schizophrenia and other psychosis, which includes delusions, hearing voices, and hallucinations; bipolar disorder, which includes mania and depression; depression and anxiety disorders; and also personality disorders, such as antisocial personality disorders or borderline personality disorder. We will include people who have major mental illness and also a substance abuse disorder, but we will not include people who have only a substance abuse disorder without major mental illness. These people also have increased risk of violence, but they're not going to be included in our analysis today. Now, the research evidence clearly shows an increased risk of committing violence among people with major mental illness. Specifically, people with major mental illness are about 2 to 6 times more likely than the general public to commit violence. That's obviously a broad range of estimates, and that reflects the disagreement of different studies that use different methods and different samples. So we know that there's a substantially increased risk, but we don't know how big the risk is on average. I am restricting my considerations to samples of the general population of people with mental illness and excluding studies that looked specifically at people with mental illness in jails and so on, because that would, of course, be misleading. About half of the victims of violence by people with mental illness are intimate partners or other family members. Only about 15% of the victims are strangers. So the brunt of the burden of this violence is felt by family members, and the general public experiences relatively a smaller portion of the violence by people with mental illness. It's important to remember that most people with major mental illness are not violent. Only a small proportion of total violence is committed by people with major mental illness. So specifically, only about 5 to 15% of people who have major mental illness were violent in the past year, which means that roughly 90% were not violent. And correspondingly, only about 5 to 15% of violence total is committed by people who have major mental illness, which means that about 90% of violence is committed by people who do not have major mental illness. We can, we can identify characteristics that increase or decrease the risk of committing violence among people with major mental illness. For example, people with schizophrenia and other psychoses are about 3 to 4 times more likely to commit violence than the general public, but the risk of violence is much lower if the person does not have any previous history of violence, if they don't have substance abuse or dependence, and if they're in treatment and compliant with treatment. So we can identify groups of individuals who have mental illness but have in fact a low risk of committing violence. The first two factors are supported by the study shown in this slide, which looked at a representative U.S. population sample and measured three characteristics at the first round of the study, at the beginning of the study. A stands for severe mental illness, B stands for substance abuse and/or dependence, and C stands for history of violence. After these characteristics were measured, the researchers followed the sample for 3 years and measured who committed violence during that 3-year follow-up period. The arrows along the bottom indicate the 4 groups that had major mental illness, either just major mental illness or in combination with one of the other characteristics. The first arrow indicates the group that had only major mental illness without substance abuse or a history of violence. That's about half of the total people with mental illness, and what you see is that group has a very low risk of committing violence, very similar to people without mental illness. If you look at the last arrow, that indicates people who had mental illness plus substance abuse plus a history of violence. And the risk of violence there is about 10 times greater than for mental illness alone. So that represents almost a quarter of the sample, and they do have a significantly increased rate of violence. Although it's important to note that the majority still did not commit violence, even in that high-risk group. You will see that all 4 of the groups that had the highest risk of violence had a history of previous violence. So the history of previous violence was a much stronger predictor of future violence than major mental illness was. And I want to caution you that although we can identify groups with low risk of violence and high risk of violence, or relatively high risk of violence, the ability to identify specific individuals who will become violent in a given time period is pretty weak at this point. Psychiatrists try and they can make some predictions, but their accuracy is not high. Now, using these results, we see indications that the pathway from mental illness to violence can be relatively complex, and I've just chosen one little part of that pathway to show here. So mental illness produces symptoms that are often unpleasant and uncomfortable, and this leads to people with mental illness self-medicating by using various substances, alcohol, or illegal drugs, and this leads to substance abuse. Now, substance abuse increases the risk of violence in at least 2 ways, and probably more. The first is disinhibition. That, for example, if you've drunk a lot of alcohol, you may have noticed that you become less inhibited, and that increases the risk of violence. And in addition, people who abuse substances are more often in situations where violence is common. So the pathways between mental illness and violence include a variety of complicating factors like substance abuse. Now we turn to homicide, a very severe form of violence, and about 10 to 20% of homicides are committed by people with major mental illness. So again, we see a significant contribution by people with major mental illness, but the vast majority of homicides are committed by people who do not have major mental illness. I want to talk briefly about multiple victim homicides in public locations. These are the ones that capture the news media and public attention and loom large in our thinking about people with mental illness. And it appears that at least half of these multiple victim homicides in public locations are committed by people with major mental illness. They get a lot of media attention, but they actually account for only about 1 in 1,000 of all homicide deaths. So quantitatively, they're not important, even though obviously they're very important to the people who are victims of these homicides and their family members and loved ones. So in summary, we see consistent evidence that major mental illness contributes to higher rates of committing violence, but that depends on the additional characteristics. The amount of risk depends on additional characteristics such as substance use and history of violence and not being in treatment. And most violence is committed by people who do not have a major mental illness. Okay, we're ready for questions and comments. Craig?
Yes, so I'm going to display one question that we've gotten. I think you can see it. How is a crime dealt with when committed by someone with a mental illness? Please connect the crime, mental illness, and punishment as elements in this situation.
So the way that a crime is treated in the judicial system varies a great deal. In some locations, there are what are called jail diversion programs, and some of them are pre-trial and some of them are post-trial. These are programs that identify individuals with mental illness and divert them to needed treatment as opposed to jail time. This obviously is more likely to happen if it's not something like homicide. So these jail diversion programs are being brought into play more and more locations and are successful in getting people with mental illness the treatment that they need. Another thing that most people have heard of is not guilty by virtue of insanity. That plea is successful in only a small proportion of cases, but is still sometimes successful. And unfortunately, for a lot of people, what happens is that if they committed a crime, they get the sentence in jail whether or not they were mentally ill. Some jails do make an effort to provide good mental health treatment, but many prisoners are not receiving the mental health treatment that they need.
Okay, thank you for that. Another question that I wanted to ask, somewhat related to the last comment you made, and that is related to this issue of the mentally ill in prisons. Do you have a point of view or perspective, or is there any research that you've come across that speaks to kind of the degree to which those that are in prison for violent behaviors actually should not be there because, in fact, a mental illness was the reason behind their crime versus malice?
That's a philosophical question that
Okay.
people could differ about, but there's certainly evidence that a significant proportion of people in jail for violent crimes, perhaps in the range of 10 to 20%, are suffering from mental illness. But what should happen to them, that's a question I would defer to someone else.
Okay, that's fair. That's a fair response. So then another question that I have, it stuck out for me when you were presenting earlier. You talked about the disinhibitory nature of the use of alcohol and drugs. What kind of struck me there is it valid to then extrapolate that our tendency in the society to want to blame mental illness for violence should probably better be kind of attribute it to, or that fault should be laid at the feet of substances that cause us to be less inhibited. Is that a fair extrapolation, or do you think, again, another philosophic question or argument?
So I think that both mental illness and substance abuse are playing a role. I think there are even more complicated factors. For example, people with mental illness more often have a history of parental abuse when they were children. And so there are preceding factors that might have contributed to both substance abuse and the exacerbation of mental illness. And so I think trying to identify a single factor is not going to give us a real answer. What we really need is a more complicated, complex view of multiple causes. And to prevent violence, which we'll talk about in the last part, we're going to have to address these multiple complex factors.
Okay, all right, well answered. Thank you, I appreciate that. Okay, no other questions at this time have been posted, so please proceed.
Okay, here come the slides. And we're turning now to the section on people with major mental illness as victims of violence. And people with major mental illness are about 3 to 10 times more likely than the general public to report being a victim of violence. This is, again, a wide range of estimates, but a substantial increase in risk of violence for people with major mental illness. A substantial increase in the risk of being a victim of violence for people with mental illness. People with major mental illness are about 3 to 7 times more likely to be a victim of homicide, and about 15 to 35% of people with major mental illness report being a victim of violence in the past year. So a heavy burden of victimization for people with major mental illness. And there appear to be several reasons for this. For example, people with major mental illness are more likely to be unemployed and to have very low income. So they're more likely to be homeless, which exposes them to violence. And they're more likely to live in dangerous neighborhoods, so they're more likely to be victims of violence. In addition, some people with major mental illness are less aware of safety risks and how to avoid them. So they're not street smart, I guess you could say. The other kind of victimization that I want to mention here is that people with major mental illness are much more likely than others to commit suicide. So the increase in risk is about 5 to 15 times for people with major mental illness compared to the general public. And 60 to 70% of suicides are committed by people with major mental illness. So you can see that the risk, the proportion of suicides that are due to major mental illness is much higher than the proportion of homicides. And this reflects the very painful symptoms that many people with major mental illness experience. So again, mental illness is an important factor contributing to victimization, and both by others and by the person themselves. So that is a brief section on victimization, and I will pause here in case there are any questions at this time.
Yeah, so no questions have come. Let me check one more place here. No questions have come in. So we should.
Okay. All right, we'll go back to the slides then. And we turn now to the final section, which is mental illness and violence. What can we do? And there's research evidence to support several approaches. Probably the best studied area is suicide prevention. There have been quite a few studies of various approaches to suicide prevention. The most effective approach in a comprehensive review that was published in 2013, actually in 2005, excuse me, the most effective approach was educating primary care physicians to recognize and treat depression and suicidality. So most people who commit suicide have been to a doctor within the past month or at least within the past year. If the physician can recognize the prodromal symptoms of suicidality and can recognize depression and treat them, this kind of program decreases suicide rates by about 1/4 to 3/4. The second most effective approach in this review was restriction of access to guns and other highly lethal means of committing suicide.
Excuse me, can I pose a question?
Yes.
Can you define for us what prodromal means?
So prodromal means that you can see symptoms of something before the full-blown expression. So you can see symptoms that a person is moving towards suicidal behavior before they actually engage in suicidal behavior.
Okay, thank you very much.
Okay, so the second most effective approach is restriction of access to guns and other highly lethal means of committing suicide. And again, we have a very broad range of estimates of effectiveness from 2%, which isn't very good, up to 1/3 reduction in the rates of suicide. Now, this brings us to the question of evidence-based gun control. And this is the 2013 report that I was thinking of in the previous slide. So this report argues for restriction of access to guns that targets people who have characteristics known to be associated with high risk for violence during time periods known to be high risk for violence. So that would include anyone convicted of a violent crime, anyone who is currently subject to a domestic violence restraining order, anyone with a recent conviction related to drug or alcohol abuse, since those kinds of drug and alcohol abuse are related to violence, and anyone recently released from involuntary hospitalization for mental illness and deemed dangerous to self or others. Again, focusing not just on individuals with characteristics that are associated with high risk of violence, but also the time periods when the risk is higher. Another approach that is supported by research evidence is preventive court-ordered outpatient treatment combined with better access to good mental health services. And this appears to reduce both violence against others and violent victimization for people with major mental illness. We need a lot more information about effective treatments, including information about treatment for substance abuse in combination with mental illness. That's quite challenging. And the role of services such as safe housing. To what extent can that help in the general well-being of the person with mental illness and in preventing violence and victimization? Now I want to bring up the issue of stigma. Stigma is associated with mental illness and violence in an unfortunate feedback cycle. So violence by people with mental illness is the major cause of stigma against individuals with mental illness. And this is particularly true because people with mental illness generally show up in the news media if and only if they do something horrible and violent. The entertainment media also tend to portray individuals with mental illness as violent, much more than the actual percentage in the general population of people with mental illness. The stigma contributes to avoiding treatment. A person who may have symptoms is reluctant to seek treatment. They don't want to be identified in this stigmatized group. They don't want others to identify them in this stigmatized group. And stigma probably also contributes to inadequate funding for the treatment needed by people with mental illness. In addition, mental illness reduces access to good jobs and housing. I'm sorry, the stigma against mental illness reduces access to good jobs and housing. And we've talked before about how that puts people in situations where they are more exposed to violence. So the stigma then indirectly contributes to a greater risk of violence, which in turn exaggerates the stigma or propagates the stigma. Ways to reduce this vicious cycle would be more responsibility by the news and entertainment media to portray people with mental illness who are in recovery, who are contributing to society, and also more people speaking up when they are individuals with mental illness in recovery, either in a public forum, which some athletes and music stars have started to do, or in our workplaces, neighborhoods, letting people know if you or a loved one has a mental illness and that you're basically functioning like other people because you're in recovery. This obviously has risks since there is associated stigma, but to the extent that it's possible, it helps to fight the stigma. Okay, so I've covered a variety of approaches that could help to reduce the relationship between mental illness and violence in the sort of public sphere, and I'm turning now to resources that you may find useful on a more personal level. We have posted on the page for this webinar the link to this deck, so I'm not going to give you time to copy down these websites, but National Alliance on Mental Illness provides a lot of services to help someone with major mental illness, including Family to Family, a structured course that helps family members understand their loved ones with mental illness and how to help them and how to help themselves. These help guides are useful not only for helping someone with substance abuse, but actually there are help guides for a variety of mental illnesses. To avoid violence in your home, there's helpful advice at the first link. If somebody is threatening violence, you probably want to read that ahead of time if you fear that might come up. And then the second bullet point gives a link for advice to help prevent a mental health crisis from escalating to threats of violence. For example, advice about how to communicate effectively and work with your loved one to solve problems. The next page shows advice for preventing suicide, and you see again the help guide, and MHFA stands for Mental Health First Aid, where you will find a variety of resources for coping with all sorts of mental illness. And now we come to our last questions and comments. So
we do have a question.
Okay.
Let me read it and then I'll post it. So the question is this. Please comment on the effect of judges being educated about mental illness. How can we advocate for the mentally ill in this arena?
I wish I knew a better answer to that. There is, of course, continuing education for lawyers. I assume there is for judges. I know there is an education course before people begin to become judges, at least in the state of Pennsylvania. How we gain access to provide information in those settings is a case for advocacy by groups such as NAMI.
All right, thank you for that. And so I know that you talked about the fact that in the deck that you've attached, and we are going to take a look at that, there's information about what we can do as caregivers in situations where we feel threatened by violence by a loved one or someone who lives in our community. But can you just succinctly kind of give us some top-line suggestions or pointers, maybe a top-line summary of what that information says about what should we be thinking of doing if we find ourselves in that kind of situation?
So the first thing is, if you feel there's an imminent danger of harm, call 911. Do not take chances, because the outcome can be horrible for you and your loved one. The second piece of advice is, if it's not an imminent danger, but it's gotten beyond your ability to control, then you want to call the local crisis line. And they can usually send trained professionals in an outreach team, or at least make you aware of where you could take someone who needs calming down. And they will know the range of resources available in your locale. Our affiliate website gives the crisis lines for the local Philadelphia suburban area. So that link was given on the first slide. The third thing has to do with keeping things calm, making sure not to escalate the situation. So making sure that you talk in a very quiet way. You generally want to make simple sentences. You want to express empathy for the person and the difficulties they're experiencing, but very calmly. In many cases, it's better to stay at some distance. Don't stare at the person. Don't hover over them, but just try and be a really calming presence. If you have any hint that you think the person might become dangerous, you need to be concerned for your own safety, and you need to make sure you're near an exit or some near a telephone, some way that you can call for help. There's much more detailed advice at the link I gave you, and also at Mental Health First Aid.
Okay, thank you for that. That's an excellent start in getting us aware where repetition is an excellent teacher. So, checking here quickly, we don't have any other questions that have come through. So I guess, do you have any?
I have one last word.
Okay, yes, please.
So I highly recommend not only thinking about how to cope as a crisis arises, but thinking about how to prevent crises, both in terms of suicide prevention, violence prevention, and general well-being. And in the link that I gave, and I mentioned about communicating better with an individual with mental illness, there is a link to the LEAP method: listen, empathize, agree, and partner. That was developed by Javier Amador, and that book is readily available, as are videos. So again, if you can start early, educate yourself, and help your loved one find their way, hopefully this will not be a personally relevant topic for you. Thank you.
All righty. Thanks all for joining, and we're going to sign off now. Please spread the word about this hangout on air so that people can come and look at the archived version. Thank you very much, and have a good day. Bye-bye.